Assalamu alaikum and welcome everyone. Inshallah, today we will continue our studying and discussion Hunter book, Learning Strabismus Surgery. Today, inshallah, we will read case number 5, traumatic second nerve palsy. Dr. Ghadir, can you please start reading?
Bismillah. A 51-year-old female computer teacher presents for evaluation of binocular horizontal diplopia. 6 months prior to presentation, she was violently thrown from her bicycle, sustaining a closed head injury with loss of consciousness for 15 minutes. Following the accident, as the periorbital swelling started to resolve, she noted intermediate binocular horizontal diplopia, worse in the distance and in right gaze. Her ophthalmologist prescribed prism glasses for a presumed right traumatic sixth nerve palsy, which provided some relief for her symptoms. But she quit using them after a few weeks because the two images became so far apart she could suppress the second image. She presents for management of her symptoms of diplopia and for recommendations to fix the limitation of abduction of the right eye. Past ocular history is notable for amblyopia of the right eye.
Okay, before you
Examination.
continue, Dr. Muhammad, do you want to make any comment about this case?
Yes, there is a lot of information here. The first information we should highlight on injury and the trauma as a cause of second nerve palsy, and we should explain this maneuver because the second nerve palsy at some point inside the skull, especially at the vitreous bone, at this site, the second nerve pulse is susceptible for injury, especially in trauma like motor like accident. Another thing here also, the diplopia is more in far than at near. This is the characteristic of sixth nerve palsy. Okay, the second thing, prism. Prism, especially prism wearing glasses, because of second nerve palsy as incomitant strabismus, which I mean concomitant strabismus, we have a lot of secondary deviation, primary deviation like 20, 30 prism, but the secondary deviation here like 50 prism. Because of that, the prism just works at the primary position and doesn't work at a secondary position. So almost all of the patient with second nerve palsy with the prism adapting glasses, most of them not satisfied because they will complain of diplopia at some point of secondary deviation. Okay, you can
Yeah.
continue.
Yes, just I want to add that always the face turn it will be toward the affected eye. So he has right second palsy, so he has face turn toward to the right side. This is one thing, and as you mentioned, there is incomitant strabismus, meaning the angle is not the same at the different type of gaze. So mostly these patients they will look toward the affected eye. This is the second point, and they have divergence weakness, and this is the cause of this diplopia is worse at the distance because of the divergence weakness. This point just I want to add here in this paragraph. Yes, Dr. Ghadir, continue please the examination.
Sorry, but I have a question. It says that the trauma was 6 months ago, and few weeks back she noticed that the two images became so far apart. يعني it got worse. Is this characteristic? Does it imply anything?
No. This is characteristic of improvement because as I mentioned before, if suppose the angle of squint like 30 prism primary position, after improvement, the angle will decrease. So the prism will not work here.
Like
Okay,
it
thank you.
was, I think, large angle, so there was no diplopia. And when it became small angle, the diplopia it started. This is what I understand. Yes, Dr. Muhammad, you get my point?
Again, you can read the paragraph here. Ophthalmologist prescribed a prism glasses for presumed right traumatic sixth nerve palsy, which provided some relief of her symptoms, but she quit using them after a few weeks because the two images became so far apart. She could suppress the second image,
Okay.
maybe increased here, and
Uh,
the patient suppressed the other image to prevent diplopia. Okay.
okay. Let us see the examination, what will happen. Maybe it will become
Okay.
more clear. Yes.
Current prescription, right eye, plus 3.5 sphere, plus 0.5 cylinder at 110, with a reading add of plus 1.75. Left eye, plus 2.5 sphere, plus 2 cylinder at 60, with the same add for reading. Visual acuity with correction in the right eye, 20/25, and the left eye, 20/20. External examination, mild right head turn is present. A 4 centimeter linear well-healed scar extends across the bony prominence of the left superior orbital rim. The left side, okay. Sensory motor evaluation, motility, left eye fixation preference. In the left eye abduction, she has limited abduction of minus 3.5. Notable abduction limitation of the right eye. This is right.
Yes, there is limitation in the right eye abduction minus
Right.
3.5. And mostly, some doctor I saw they differentiate between its partial sixth nerve palsy or its fully sixth nerve palsy, partial or full paralysis.
Or
So,
complete.
yeah, or complete. Complete, they mean always if you see the abduction, it reach mostly -5. And some book they write it's more than -4. So they think if more than -4, this is complete. Less than -4, this is mostly partial sixth nerve palsy.
Dr.
Uh, yes,
Abdurrahman, for our references, we graded from +4 to -4. +4 means maximum overaction of the muscle. 0, there is a normal action of the muscle. -0 is fully under action of the muscle. I didn't hear any time about -5.
I saw
-4
it.
to +4.
Yes, yes, I read it. I read it -5, and I read more than -4. They said this is complete. -4 and more, this is complete. Some book they mention it. Okay, there is other things about how to differentiate. Yes, please continue, Dr. Ghadir.
Okay, there is notable abduction limitation of the right eye. There was good scaedic velocity of the right lateral rectus muscle on attempted abduction.
Yes, I think this is an important point. Yes, continue.
Deviation, distance when near, distance isotropy of 56 is this degrees ولا diopter?
Distance with correction, CC, with the glasses.
Distance with correction isotropy of 56. When near isotropy of 25. So it is more in the distance. And then in primary position, we have 56 degrees. In right gaze, we have large ET. In left gaze, we have ET of 52 degrees. And looking upward, we have ET of 56 degrees, downward ET of 52 degrees. So it is the highest on looking to the right.
Yes.
Sensory testing, diploptic response, dilated fundus examination within normal limits in both eyes, review of neuroimaging of obtained previously revealed no evidence of traumatic brain injury or specific lesion of the sixth cranial nerve. There was a small focus of single abnormality in the right parietal periventricular white matter of no clinical concern.
Okay, thank you, Dr. Ghadir. Yes, Dr. Muhammad, do you want please differentiate between the partial and complete?
Yeah, before we go to surgical plan or a surgical correction, we should focus on the causes of sixth nerve palsy as at age group. At age group, I mean at pediatric age group, at adult age group, at old ages. And another thing, you should differentiate between medical and surgical cause. Really, at pediatric age group, rarely, and you can say very rarely, sixth nerve palsy as congenital. I asked a lot of pediatric ophthalmologists about congenital sixth nerve palsy. Never of them told me anyone can did see the cases with congenital sixth nerve palsy, but most of cases with sixth nerve palsy were adult or old age groups as a causes, as mentioned before, trauma and also medical as hypertensive or diabetic, or sometimes due to infarct, tumors, demyelination. Regarding the site of the lesion, you should study the course of sixth nerve palsy from the bones and also due to intracranial pathway and also inside the cavernous sinus and also the course toward the eye. I can add some points. Sixth nerve pulse cannot be isolated in nuclear origin. It should be associated with seventh nerve pulse due to the seventh الفيشال nerve palsy surrounded the nucleus of sixth nerve at the bones. Because of that, sixth nerve in nuclear in origin, it should comes seventh nerve palsy. And also, I can add another point. If you see a case of sixth nerve palsy with Horner syndrome ipsilateral, mostly the lesion, it should be inside the cavernous sinus. And also, you can see another cranial nerve like a third nerve and fourth nerve, and also the first two divisions of the fifth nerve trigeminal, because all of that inside the cavernous wall. Another thing,
Dr. Muhammad, sorry for interruption. Can you check your connection? There was some interrupted in your voice. Your connection is unstable.
one minute.
Okay. Please, anyone also from the audience, if he want to ask after Dr. Muhammad finish, please he can ask. Yes, Dr. Muhammad, continue.
Okay, this is the most important point while you are examining a patient with a sixth nerve. This is the first one. The second thing we will discuss, inshallah, later on the surgical plan for patient with sixth nerve palsy. You can continue right now.
May I ask, in the examination, they said she has a laceration on the left side, but her limitation is on the right side.
It's a
The
trauma.
laceration?
Here they mentioned that the scar extends across the prominence of the left superior orbital rim, and he has right sixth nerve palsy.
Okay. This is association with the trauma.
Yes, the same thing. Okay, Dr. Ghadir, continue the assessment and the plan.
Assessment and plan. The incidence of unilateral abducent nerve palsy has been reported to be as high as 2.7% in the head trauma cases. There is a wide variability in the reported rates of spontaneous recovery.
Before we continue, just here at the picture in the primary position, you can see very clearly the right eye esotropia. Okay, and when you told the patient to look at the right side, you can see the limitation of the movement. There is no abduction at all. And here you can see the full adduction of the right eye and abduction of the left eye. So here they mention it's grade 3.5. So here, because it's just go through the midline a little bit, Dr. Muhammad, so they said the 3.5. How you know it's a 3 or 4 or 2 exactly?
It doesn't cross the midline at all, it's -4. If like very, very tiny movement, it's like 3.5, like in this patient. You should have a video of this patient to say this is -4 or -3.5. And I can share you the range of the motility of the any muscles from +4 to -4.
Okay, okay. Let us continue. Yes, Ghadir, please.
Of these injuries, and therefore I do not recommend surgery for at least 6 months from the time of injury in order to allow for spontaneous improvement or recovery. However, this may be complicated as the clinician can mistakenly conclude that there is no recovery of the abducent nerve palsy or that there is a complete palsy, where in fact the esotropia and lack of abduction are due to secondary contraction of the medial rectus muscle. This is important to know preoperatively, as it can affect surgical decision making. In complete abducent nerve palsy, the nerve and muscle are too weak to generate enough force to rotate the eye beyond the midline. I approach these cases with a transposition procedure of the vertical rectus muscle. Well, he means the complete palsy transposition procedure for the vertical rectus muscle, which may be combined with a weakening procedure of the ipsilateral medial rectus muscle. In a partial abducent nerve palsy, I recess the ipsilateral medial rectus muscle and resect the ipsilateral lateral rectus muscle. To help differentiate between the partial and the complete abducent palsy, I evaluate scaedic velocity by asking the patient to look quickly towards the affected side. If I observe good scaedic velocity followed by an abrupt stopping of the eye when it reaches the midline, this implies that the abducent nerve and lateral rectus muscle are generating enough force to abduct the eye, and that the abduction limitation is caused by restriction of the ipsilateral medial rectus muscle. In the eye, if the eye appears to float towards the midline, this suggests that the movement of the eye is occurring only as a result of release of medial rectus muscle tension and not because of restriction. If I am not certain about the scaedic velocity, I'll perform an active force generation test in the office. This is accomplished by administering topical anesthetic, usually several drops of paracaine, followed by several seconds of holding a proparacaine-soaked cotton tip applicator at the limbus. I then use a toothed forceps to secure the eye and feel the force as the patient looks in the field of action of the presumed paralytic muscle. This is followed by force duction testing.
Okay, before you continue, so here they mention about generated duction test and force duction test. So here in the generated duction test, just in a simple way, the patient, he is waking up, he is not sleeping, not under GA, just under local anesthesia. You bring a forceps and you try to force the direction of the eye to opposite the direction of the patient he tried to do. Like if you tell the patient, look at the right, you try to push the eye toward the left, and you see how much the resistance there. If there is good resistance or mild resistance or no resistance at all, this is how you know this is partial palsy or complete palsy. When he is just walking up, especially in adult patient, for seduction test, it's you will do it under general anesthesia, and I think everyone he do it in many cases to see this is restricted or palsy muscle. You will see the contracture of the muscle or no movement. This is mean due to trauma, or there is contracture there, or restricted muscle, we call it. And if there is movement without any restricted, this is due to palsy, nerve palsy mostly. So this is the differentiate between the two tests. I hope it's clear. The other thing here, they mentioned the saccadic velocity. Tell the patient to look quickly to the right and left, and you see the saccade. Can you, Dr. Muhammad, please explain the saccadic velocity to differentiate? Here they explain it very well. Just uh, to summarize this
Uh,
paragraph.
all of these tests just examine if the lateral rectus here has a tone or very weak tone or no tone at all. All of this examination, sorry, just 1 minute.
Okay. So here, according to the saccadic velocity, you tell the patient to look at the right. So they mention if there is no movement, or they said here float toward the midline. Float toward the midline, that means here there is complete palsy. But when you see there is a good saccadic velocity followed by an abrupt stopping of the eye because there is contracture in the medial rectus palsy, here they mention mostly this is partial sixth nerve palsy because the plan of surgery is different. When you talk about complete sixth nerve palsy, here mostly we will go for transposition of the muscle. But when you said this is partial, I'm talking about surgical plan. When you said this is partial sixth nerve palsy, here we can go for medial rectus recession and lateral rectus resection. Mostly we will go for recess and resect. You will work at the horizontal muscle. But when you talk about complete, you need other muscles to help the lateral rectus muscle to work, like a
I agree with
transpose.
you.
Yeah, like you are making a transposes of forces of the vertical muscle toward the horizontal gaze. This is what the meaning of transposition of the muscle. Yes, Dr. Ghadir, can you please continue?
In this patient, given the good scaling velocity, I prefer a recess rectus procedure over a transposition. To further predict what the possible surgical approach may be, I sometimes inject botulinum toxin A, Botox, into the medial rectus muscle. By temporarily weakening the medial rectus muscle, the strength of the lateral rectus becomes more apparent. I typically inject 2.5 units of Botox into the medial rectus muscle for a mild -1 limitation, 4 to 5 units of moderate for moderate -2 limitation, and 6 to 7.5 units for large -3 or greater limitations.
I think these numbers are very nice here. So here we have more than -3, so I think he will go for 7.5 unit of Botox. Yes, Dr. Ghadir, procedure.
Procedure Botox injection, right medial rectus muscle, 7.5 units.
Dr.
Post-procedure
Abdulrahman,
assessment.
Yes, Dr. Muhammad.
sorry, Dr. Abdulrahman, generally, if you have a patient with sixth nerve palsy, you will wait for how long to see if there is any improvement or no?
Mostly 6 months.
Okay, if you have this patient with 6 months and after 6 months, you can see an improvement, but very slow. You will proceed to procedure or you can wait here.
Maybe did you start for him like prisms, like
Yes,
Fresnel prisms, or not at all?
yes, yes.
you start for him.
But here the improvement very slow. Here the point I should highlight it here. If you have any improvement, at which time, if after 3 months, after 6 months, after 9 months, you should wait.
You should wait.
If you have no improvement, for example, after 4 months, you shouldn't wait. Here you shouldn't wait. You should go for surgery. So the 6 months and 1 year, it's a not cut point. It's a cut point for no improvement. If you have no improvement, but if you have a very slow improvement, you should wait here.
Okay, nice point, Dr. Muhammad. Yes, Dr. Ghadir, continue.
Another thing, Dr. Rahman, for progression detection, I always take a picture for this patient, especially for the lateral movement, for lateral action, like -4, -3, -2, -1, 0, like this, by pictures. Also by recording the information of this patient, and also by the pictures.
Thank you. Is my voice clear, Dr. Muhammad?
Yes.
Okay. Dr. Ghadir is here? I don't think so.
Yes, I'm here.
Yes, please continue.
Okay. Post-procedure assessment. 10 days following the Botox injection, she returned with a marked improvement in her symptoms of diplopia. The sensory motor evaluation revealed an esotropia of 4 prism diopter to 6 prism diopter in the primary position, with a persistent -3 limitation of abduction and a -1 limitation of abduction in the right eye, and no vertical strabismus. No ptosis was noted. Interim visit. 2 months following the injection, the esotropia had recurred. She had a 20 prism esotropia in distance at near that increased to 25 in the right gaze and decreased to 16 in the left gaze, and 4 additional units of Botox were administered to the right medial rectus muscle. Again, with a good response. She returned 4 months following the second injection, reporting that her diplopia had returned, and she now wished for a more definitive surgical treatment.
My question here, Dr. Muhammad, here she developed again diplopia and esotropia after 4 months. Sorry, they mentioned 2 months following injection. And he re-inject again with 4 units of Botox. Why he didn't go for surgery after the first injection? Why he just re-inject for the second time? There is any rule for this? You should re-inject or go for surgery? You are mute, Dr. Muhammad. Can you please unmute yourself?
Dr. Abdurrahman, I have interruption in my connection. Again, the question.
The question why he re-inject again. Here they mention after 2 months, the patient he come again with esotropia and diplopia. Then they re-inject again with 4 units. 4 additional units of Botox were administered. Why? In this case, he didn't go for surgery after the first injection of Botox.
Because I think the author here or surgeon here think about the residual. You can hear me?
No, you have interruption in your voice.
Again, the author here think about this patient can benefit from the Botox with resolution of the diplopia, and also the lateral rectus will gain again the motility.
Okay. Okay, let us continue. What will happen later on? Yes, Dr. Ghadir, continue.
Okay. Post-Botox examination, visual acuity in the right eye 20/25, left eye 20/20. External examination, right head turn of approximately 5 degrees. Sensory motor evaluation, right eye, limited abduction by -1, left eye full, abduction versions, mild abduction limitation in the right eye. Deviation, corrected for distance, ET of 20 degrees, or diopter, I don't know. Right head turn to
Prism
near,
diopter mostly. Yes.
okay. Corrected deviation for near, ET 14 prism diopter with right head turn of 5 degrees. In primary position, the patient had esotropia of 20 prism diopter with right head turn
Right,
to
I think hypertropia here or right head turn.
uh,
I think right
I don't know.
hypertropia
Right
maybe.
hypertropia too.
Yes, right
Okay.
hypertropia. Yes.
Right hypertrophy. Thank you.
Mm.
In right gaze, she had ET of 20 degrees, and left gaze ET 25 with right hypertropia of 4 degrees. An up gaze ET of 16, down gaze ET 25, right hypertropia 4. Dilated fundus examination was within normal limits in both eyes.
Okay, Dr. Sarah, you want to ask? You make hat up. Yes,
Hello
Sarah.
everyone. Hello Dr. Ahmed Rahman. How are you?
Yes, welcome, Dr. Sarah.
Thank you. Just to comment on the Botox, repeated Botox injection here. I think you want to decrease the residual angle of esotropia, as Dr. Muhammad said, because the sixth palsy get benefit from Botox injection. Some cases get يعني completely healed with Botox. As it is يعني rapid resolution, spontaneous resolution with Botox, but sometimes we can decrease the residual angle with Botox. So he repeated the dose.
Okay.
Some authors tried this situation.
Like when you paralyze the contracture of the medial rectus, so again, you will
Yes.
decrease the residual of this esotropia and you will improve the abduction of the lateral rectus.
Yes,
Okay.
exactly.
Yes. Dr. Muhammad, do you want to add anything before we go to the assessment and the plan?
Yes, you can give me 5 minutes in Arabic.
Yes, please talk in Arabic.
طيب.
يا ريت.
I will translate after
Okay.
you finish. Yes.
باختصار شديد، المريض اللي احنا بيجينا عنده سكنير بالسي. طبعا في البدايه احنا بنقيس زاويه الحول في البرايمري بوزيشن. على سبيل المثال عنده 30 درجه في البرايمري بوزيشن، في السكندري مثلا عنده 60 درجه. بنشوف الاكسترا ايكوال موتاليتي. اول شيء لازم نشوف الكوز. طبعا قبل ما نروح لاي كوريكشن لاي شغله لازم نشوف شو الكوز. الكوز طبعا ممكن يكون تيومر، ممكن يكون مثلا هيموريج، ممكن يكون انفاركت، ممكن يكون ديمارينيشن. اي كوز بنحول هذا المريض لنيورو ايميجينج، واخصائي النيورو سيرجن مكمل معه. بالنسبه لنا في الاكيوت ستيج، هذا المريض ايش الشكوى الاساسيه عنده؟ الشكوى الاساسيه عنده الدبلوبيا، مشان هيك هو ماخذ فيسترن تورد اللي هو يعني لو كان عنده رايت سيكنير بولسي بيكون عنده رايت هيتر. فانا على اساس اخفف من هذا الكلام بدي اعمل له باتشنج. كيف بدي انصحه يعمل باتشنج هذا المريض؟ بحكي
Dr.
له انت لما
Muhammad,
تطلع
let me just translate. So Dr. Muhammad, he told us when the patient came to your clinic, first of all, always you should search about what is the cause, and the MRI, it will lead you. And if there is neurosurgical cause, you should refer him to the neurologist to see the patient. The second thing, you should always see the patient in the primary position and see where is the limitation of movement, and you should see the extraocular motility, and you see where is the limitation of the angle. And always these patients, they came complaining of diplopia. This is the main complaint, especially when he look at the distant. This is, I think, the first point of his discussion. Yes, Dr. Muhammad, continue about the batching.
فالانستركشن اللي انا بحكيها للمريض، بحكي للمريض العين اللي صار فيها سكنير بالسي بنعملها باتشنج طول اليوم، الوقت اللي انت بتكون فيه برا البيت. بس لما بترجع على البيت بدنا نعمل باتشنج للساوند اي اللي هي النورمال اي، ولازم لازم يستخدم العين اللي فيها سكنير بالسي. شو الهدف من هذا الكلام؟ الهدف من الخطوه الاولى انه انا امنع الدبلوبيا لما المريض يكون برا البيت. الهدف من الخطوه الثانيه انه لما حكينا يعمل باتشنج للنورمال اي، انه انا بدي اياه يستخدم الميديا ريكتس اللي هي في العين اللي انضرب فيها السكنير بالسي، علشان على اساس ما يصير عنده كونتراكشر في الميديا ريكتس، لانه لو صار كونتراكشر في الميديا ريكتس انا راح يعمل لي هذا الكلام مسليدنج على ال3 شهور او ال6 شهور، انه هذا المريض ممكن ما تحسنش. باختصار، لو في عندي ميديا ريكتس كونتراكشر واللاتر ريكتس جين سم امبروفمنت، بس لانه بسبب الكونتراكشن للميديا ريكتس وانا بعمل في الاكسترا اوكال موتاليتي هاي العين doesn't cross the midline، فانا ممكن انخدع واحكي عن هاي العين انها لا كومبليت سكنر بلسي، وهذا المريض ما صار عنده ريزوليوشن، وهذا المريض لازم اروح اعمل له ترانسبوزيشن للمسلز، اروح امسك السوبيريور ريكتس او امسك الانفير ريكتس اعملها ترانسبوزيشن واحطها عند اللاتر ريكتس. لا،
طيب
لو كنت اعرف انه هذا المريض عنده كونتراكشر في الميديا ريكتس، تمام، او حتى منعت الكونتراكشن ميديا ريكتس وعرفت فعلا انه اللاتر ريكتس جين سم ريزوليوشن جين سم تون، فانا ممكن اعمل هون اللي هو ريسكشنال لاتر ريكتس اند وريسكشنال ميديا ريكتس، فباختصار السيرجيكال بلان راح يختلف.
Okay, let me try to translate this. So the first of all, he talking about the patching. Patching, first of all, we should do it for adult patient, not for small children or infant too, because they will develop suppression and amblyopia. So when you have adult patient, you tell him to patch the normal eye. The normal eye, you should patch it for 1 day, 24 hours. And what's that will help you? So after 24 hours, first of all, you prevent the diplopia for this patient. So you relieve the symptoms. The second thing, you will relieve the contracture of the medial rectus muscles
Again,
after the
Dr.
patching.
Abdurrahman, you should batch the paralyzed eye. The
Normal
paralyzed
eye.
you should bat the paralyzed eye the most time, but or the most time outside the door, but inside the door you should batch the normal eye and use the paralyzed eye to prevent contracture of medial rectus.
So outside, you patch the
The paralyzed
paralyzed
eye,
eye. Inside
yes,
the home, you patch the normal eye.
yes,
Okay, okay, I get your point. To prevent the diplopia outside and inside to try to relieve the contraction of the medial rectus muscle when you
yes.
patching the and this patching it will help you in the assessment of the angle and in the assessment if it's complete or partial in the next day. This is what you mentioned too, yes?
لا مش نكست داي، هي الفكره كلها انه انا بعمل هذا الباتشنج في البيت على اساس امنع يصير عندي ميديا ريكتس كونتراكشر، لان هاي
Okay,
لو حصلت الميديا ريكتس كونتراكشر مستقبلا انا راح تمنعني اعرف انه صار عندي ريزوليوشن ولا ما صارش عندي ريزوليوشن لللاترال ريكتس، لانها
okay,
راح تكون
so
شاد العين تورد الابدكشن،
so the
ما راح تعمل الكروسنج للميد لاين.
So here, the main point he focused about it, Dr. Muhammad, you do the patching to prevent the contracture of the medial rectus. And this, it will help you in the assessment and evaluation and deciding which type of surgery you will do later on. This is what he mean. Okay, let us continue now. Dr. Ghadir, can you read? I try to translate because I know there is some foreigners here. They didn't speak Arabic. So this is, I try to make the session in English as much as I can. Yes, Dr. Ghadir, please continue.
Can we switch, please?
Okay. Dr. Isra, can you read? Isra, did you hear me?
Yes, hello.
Yes, please. Assessment
From
plan.
okay. After two Botox, can you hear me well?
Yes, continue.
After two Botox injections to the ipsilateral medial rectus muscle, the alignment has improved and the lateral rectus muscle now clearly show good residual function. By 4 months, the Botox should have completely worn off, so there is no reason to expect that the alignment will change further. Therefore, I will perform an adjustable right medial rectus resection and a non-adjustable right lateral rectus resection. operating for 25 prism diameters. From the surgical table, Appendix 2, that means a recession of 4 mm and a resection of 5 mm. Surgery, right medial rectus recession, 4 mm adjustable, right lateral rectus resection, 5 mm non-adjustable. Post-operative assessment in the recovery room, cover testing showed no shift at distance or near with no diplopia. There was minus 0.5 limitation of abduction of the right eye with no adduction limitation. No suture adjustment was performed.
Okay, let us. So, what did you think, Dr. Muhammad, about here this number of surgery and he go for recess
Yes,
resection?
yes,
Yes. 4
I
and
agree with
5, it
this.
will correct it 25.
Yes,
Like 4 and 5 for me, it will correct mostly 22.5 for me. So I will do like 5 millimeter resection and 5 millimeter recession. It will give me 25 for my calculation in my table.
okay.
Yes, but you believe 4 and 5, it will give you 25 here.
Yes.
Okay. So there is a lot of table. Maybe we will talk about table later on. Yes, Dr. Isra, follow up.
Follow-up. At the most recent follow-up visit, 3 months after surgery, the patient reported that she had no diplopia at distance or near. Visual acuity with correction, OD 20/20, OS 20/20. External examination, no anomalous head position was present. Sensory motor evaluation, motility, ductions and versions are full.
Yes, here we can see the picture. They mentioned duction and version. Dr. Muhammad, can you tell us the difference between duction and version? What does that mean?
يس دكشن الفكره انك تعمل اكسترا اوكيولار موتاليتي لعين واحده، تغمض العين الثانيه وتعمل اكسترا اوكيولار موتاليتي لعين واحده. تمام. الفيرجنس انك تعمل اكسترا اوكيولار موتاليتي باستخدام العينتين. الفيرجنس انك تعمل اللي هي الكونفيرجنس والدايفيرجنس. فباختصار كلمه دكشن ايكوال مونوكولار تيست، الفيرجنس ايكوال كونجوكيت باينوكولار اكسترا اوكيولار موتاليتي. الفيرجنس not synergetic in synergetic not conjugate in conjugate sorry synergetic in conjugate binuclear extraocular modality.
Okay, let me just try to summarize it. So when we said duction, you see the motility in one eye. You patch one eye and you tell the patient to look right and left, so you will see the duction in one eye. Version, you will examine the motility in both eye, like in conversions when he looked to the near object with his both eye, or divergence for far object.
No. Vergence, no. Vergence, binocular synergetic conjugate extraocular motility. Like right gaze, left gaze, up gaze, down gaze.
Yes. In both eye.
Dextro elevation, dextro depression, levo elevation, and levo depression.
Okay, so
The,
you will
the
examine
vergence,
the motility in both eye together in the same time. Yes.
the last thing, vergence, it's about the convergence and divergence. It
Yes.
equals not conjugate binuclear extraocular motility.
Okay, thank you, Dr. Muhammad. Okay, continue. Isra, please. Deviations.
Deviations for distance with correction, she has esotropia, 2 prism. Near with correction, she's also. In primary position, there was esotropia, 2 prisms. In right gaze, ET 4 prisms. In left gaze, ET 2. In up gaze, ET 1 prism. And in down gaze, she's also.
Yes, continue.
Review. Injury to the sixth cranial nerve is a common occurrence after head trauma. The clinical examination is characterized by symptoms of binocular horizontal diplopia worse at distance than near, and limitation of abduction of the affected eye, which creates an concomitant esotropia. Although there can be spontaneous improvement of ocular motility following this type of cranial nerve injury, often the recovery is incomplete either due to severity of the injury or to shortening or contracture of the opposing medial rectus muscle. Treatment options are determined by the degree of ocular misalignment and amount of residual lateral rectus function. In this case, I utilized Botox to clarify the degree of residual lateral rectus function by reducing the confounding secondary contracture of the medial rectus muscle. In some cases, the esotropia completely resolves after Botox injection, though in many cases this is the result of spontaneous recovery in patients who are treated early in the course of the condition. This patient showed an excellent response to Botox injections, and I concluded that there was only a partial abducens palsy, that the strabismus recurred, and I proceeded with a successful unilateral recess resect procedure.
Continue.
Although I didn't use an adjustable suture on the lateral rectus muscle in this case, I recommend using adjustable sutures on all recessions and resections when repairing nerve pulses in order to have maximum flexibility when adjusting in the post-operative period to maximize the zone of single vision. I previously used to only put the medial rectus muscle on an adjustable suture, and as in this case, when operating on small angle esotropia with a -1 limitation of abduction. But now I almost always put both muscles on an adjustable suture.
Yes, before we go to the review question, Dr. Muhammad, do you want to add anything here?
No.
Okay, continue. Isra, then we will summarize the case, yes?
Review questions. First, in acquired abducens palsy, is the esotropia usually greater at distance or at near? The isodeviation is usually greater at distance because the eye naturally converges slightly for near viewing, reducing the contribution of the lateral rectus muscle to the eye position. Second one, what four clinical tests help determine whether the lateral rectus muscle has recovered function in a patient with chronic abducens palsy? Uh, Four tests: saccadic velocity assessment, force generation testing, force reductions, and response to Botox injection. Third question, what procedure might be considered if a patient with a chronic abducens palsy shows floating saccades, no active force generation, and free force reductions? The clinical findings above are consistent with the absence of abducens nerve function, meaning that a resection of the lateral rectus muscle will be ineffective. This hypothetical patient will likely require a transposition procedure of the superior plus or minus inferior rectus muscles, possibly combined with a weakening procedure of the ipsilateral medial rectus muscle.
Okay, thank you so much, Dr. Ghadir and Isra, for reading. Before I go to the surgery, let us talk about the surgery types here in thick nerve palsy because this is our interest. Anyone have any question? Dr. Muhammad, do you want to add any points before we go to the surgeries?
Here we should discuss the types of transposition surgery in thick nerve palsy, because here we have a lot of options. In contrast to third nerve or especially in complete third nerve palsy.
Okay.
Because in third nerve palsy, we have a very limited approaches to resolve the squint there. Okay.
Okay, let me try to summarize this, please. So first of all, we will talk about what is the plan of our surgery. Like after 6 months, you do after you give him the Fresnel prisms, the patching, everything.
Fresnel prism.
Fresnel prism, and now you decide to go for the surgery, and there is no any improvement, even mild improvement. So mostly they divide it if it has partial thick nerve palsy, as we mentioned, how to know it's partial or not. They mention here 4 tests. If you remember in the second question, number 1, you see the saccadic velocity assessment. There is movement or there is no any movement or mild movement by force generation testing and force reduction test and response to Botox injection. So this is how they differentiate. This is partial or complete. If there is no saccadic movement by force generation. There is no any resistance, and by force reductions also there is total palsy or not, or there is some resistance, and there is good response or no response to the Botox injection. All of these, it will help you to differentiate. So if there is partial sixth nerve palsy, they prefer, as I mentioned before, recess resect. They will go to the medial rectus recession and lateral rectus resection. And now we will talk about the doses, how much I will resist the medial rectus muscle and how much I will do for lateral rectus. It depends on the how much the contracture of the medial rectus and how much the angle. And in some cases, in my practice, we go for the maximum. I have one case actually of sixth nerve palsy. My senior told me to do the maximum of medial rectus recession and lateral rectus resection. And the medial rectus recession in these cases is very difficult because it's totally contracture and tight muscle, and it's not easy to release the muscle. So my plan was to do 7 medial rectus recession and 14 lateral rectus resection. And actually, during this surgery, as I remember, I have slipped muscle of the medial rectus. It's not an easy. There is a lot of contracture. The muscle, it slipped with me. So it's one of the difficult case of surgery. Now I will talk about the transposition.
14 millimeter resection of lateral rectus, or you mean 14 lateral rectus recession? Recession or resection for lateral rectus?
Resection. Resection.
Resection is very high. I don't
Yes,
think.
yes, but we go for 14.
Yeah, if you know the super maximum recession and super maximum resection of the medial rectus and lateral rectus in third nerve, here the maximum number for medial rectus resection here is like 8.5, and the maximum recession here for lateral rectus it's like 14 to 15. But I don't think this is the same number regarding the resection of the lateral rectus.
It's
Please, if
different.
you
I
can.
talk about recession medial rectus, not resection. I talk sixth nerve. Sixth nerve resist the medial rectus and resect the lateral
I
rectus.
know,
Yes, I
I
know
know,
it's
I
very
know, I
high.
know it.
Yeah, I believe it's very high number, but I saw it and I did it before. Okay. So there is variation, Dr. Muhammad. I'm not talking my number is correct and you should do that. I told you my just experience and what's happened. And actually, the patient, he has like about 120 prism diopter esotropia, and the next day after slipped muscle, he was happy. There is no adduction, no abduction, but the eye it was, in the primary position after this 14 millimeter resection of the lateral rectus. You pull the eye to the lateral side, and he was happy because he just want cosmesis. He didn't see in this eye. He's totally amblyopic. He's adult patient, 29 years, and he has a sick nerve palsy since childhood. So he was happy. His eye, it become in the center. You get my point? I know it's very high number, but just I told you one case of my experience. Let me go to the transposition now. So try to we have Hamel-Shim procedure. We have Jensen and other doctor they call it Janssen procedure, and we have Nishada procedure. I will start with the Hamel-Shim procedure. So in Hamel-Shim, you transpose half of the tendon of the superior rectus and half of the tendon of the inferior rectus. So what is the point here? You make a splitting. Look, there is a splitting here. And this is splitting, it's about 14 millimeter. So you do like 14 millimeter posterior splitting. So you split the muscle into two half, the upper half and the lower half. So this is the lower tendon, and here this is the upper tendon. So what is the benefit of this procedure? The first of all, look here, this is the anterior ciliary artery. So when you're splitting in the center, you will not touch the anterior ciliary artery. So this one advantage point. So we see the anterior segment ischemia here, it's less. It will not happen as you transpose all of the muscle toward the lateral rectus. So they go for transposition only the inferior half. So look here, the anterior ciliary artery, it is still safe. So you split the two tendon 14 millimeter posteriorly, then you just transpose the inferior half of the tendon and here the superior half of the tendon. And here you have two options. Some of the doctor, they just make a stitch here between the two muscle, and other they go like about 8 to 10 millimeter posteriorly. They put a one stitch here and they call it augmented procedure or posterior fixation. Why they put a one stitch between the two tendon here? To increase the power or the vector of the forces of that action of that muscle. So you can put sutures here, or you can just fixate it here anteriorly to the scleral or to the scleral also with the muscle. So there is augmented and there is Hammersheim only without augmented. Let me go to the, we call it Jensen, but I hear other doctor, they call it Janssen.
But before you go to Hamalshin, sorry for Janssen, Hamalshin here, because of you, you should disinsert the superior rectus and inferior rectus here. It's forbidden to do this insertion for medial rectus as a recession for medial rectus here because of more than or three or more than recti muscle. You will maybe have an anterior ischemic syndrome. So this is the disadvantage of Hamalshin procedure here.
Yes. I hear Dr. Muhammad that they didn't prefer do it also in Jensen because medial rectus decision you will work at a three muscle. In Hamalshin, because you split the muscle into two tendons, so the risk of anterior segment ischemia is still less. Here they mention augmented Hamalshim with resection. What is the resection? When you just shift the inferior half of this tendon, you do resection about 4 millimeter of this tendon. And when you make resection of 4 millimeter, they said this resection also, it will increase the power and the effect of the Hammersheim procedure. So actually what you are doing, you transpose the forces toward the horizontal gaze. Okay. Now let me go to the Jensen procedure. Okay. Then we will go for Nishada. So in Jensen procedure, look here, they make splitting inside the muscle, and also they splitting here the lateral rectus. But what they exactly, they didn't transpose the superior and the inferior recti. They make the opposite. They take a stitch of this superior tendon. Dr. Muhammad, you are unmute. Okay. So here they take the lateral rectus after they split it into two halves, the superior one and the inferior one. Then they make a stitch with half of the lateral part of the muscles, one stitch, and another stitch with half of the lateral belly of the inferior rectus. So you give more powerful toward the lateral side. But here there is risk because you make splitting in three muscles. Maybe you will touch the anterior ciliary artery.
But
Okay,
here
this
you can add a medial rectus recession
you can
as
add.
advantage of this procedure.
Okay, that's the opposite. So in Jensen you can add, but in Hamalshim you can't add.
Yes.
But I don't know, I read it in the Strabismus Atlas, they said you will save when you make splitting and you just transpose half of the tendon. You will save the anterior ciliary artery. Okay, we will go to the Strabismus Atlas book to see the picture there also. Okay, let me last talk about the transposition of the superior rectus. This is very
This
rarely.
is
Yes,
No, this is the preferred maneuver in my hospital in
in my
Egypt.
hospital, it's very rarely, no one do it. So
Okay.
every hospital. Okay, tell me, Dr. Muhammad, how they do it, transposition?
It's a full tendon, superior rectus transposition toward the lateral rectus with a medial rectus section easily.
Yes, so you transpose all of the superior rectus toward the lateral side. You put it here beside the lateral rectus, and you do recess the medial rectus. And
But you
it's
know,
work, yes.
we do some resection for the superior rectus like 4 to 5 millimeter after transposition to lateral rectus, and as I mentioned before, with medial rectus resection.
Okay, thank you so much. Okay, let me talk about Nishida procedure. In Nishida procedure, they try to decrease the injury of the anterior ciliary artery, so they make Nishida and modified Nishida. In Nishida, they make a transposition, but they make the transposition just by a suture without connecting each muscle to other. So here as you see here, they split half tendon of the muscle of superior rectus, and with a suture they go to the midway between the superior rectus and lateral rectus, and this midway they put a suture about 12 millimeter from the limbus, and the midway between superior and lateral rectus here, it will be in the center. They put a suture. So they transpose the forces of the superior rectus toward the lateral side by a suture here, mostly uh, absorbable suture. And another thing for the inferior rectus. They make a modified, and also they make this Nishada procedure for monoocular elevation deficiency for the superior rectus. They transpose the medial rectus effect here and the lateral rectus effect here also, especially when we have superior rectus palsy. We will talk about monoocular elevation deficiency later on. But in the modified procedure, they didn't do any splitting of the tendon, and they move it. Just they do a stitch. Here in the superior rectus, they take from the lateral part, they enter about 1/3 of the muscle. This stitch enter about 1/3, 10 millimeter from the muscle here. And this stitch, they measure the distance between the lateral rectus and superior rectus midway here. This is the midway between the two muscles, and measure about 12 millimeter from the limbus to here. And they put one stitch in the superior rectus and one stitch in the midway between the two muscles here at the sclera. So this is the modified Nishida without any splitting of the superior or inferior rectus muscle. This is, we call it modified Nishida. I think this is all about the surgery, Jensen and Hammershim and Nishida and modified Nishida. I hope I add something about this surgery and it become more clear. And Dr. Muhammad, do you want to add
Mm,
anything?
Yes, again, our routine in my hospital is SRT. This is a superior rectus transposition with medial rectus recession. If it failed, we can add inferior rectus transposition to it.
Again, please, can you summarize it again? First of all, you will do,
Superior rectus transposition with medial rectus recession. If it failed, we can add an inferior rectus transposition, full tendon.
yes, this is here just again some pictures of the Strabismus Atlas book. This is very nice book. You can see all of the procedure here. So here they mentioned the Jensen procedure, and you can see how they splitting here the lateral rectus and the superior and inferior. Then they attach,
You
yes,
should split the muscle by hooks, not by venous or scissor.
yes, like here, two hooks. Yes,
Yes, a blunt splitting. It's not a sharp splitting.
again here it's a blunt splitting.
Blunt
Yeah.
splitting by muscle hook, and also another thing, never ever do any cautery for any muscle.
During transposition or in general, you say?
Anything in general.
Okay, actually we do in my practice. Okay. What is the risk of cautery, Dr. Muhammad?
Necrosis of the muscle.
Yes, of course. Okay, so here you can see how they made the stitch between the half tendon above and here the lateral. Okay, and here the other one. This is Jensen or Janssen procedure, you can call it. They use 5-0 Mercellini suture. Here it's become more clear. You can see it at this picture. Just to make these surgery are clear, the final result here of Jensen procedure in this picture. Now in Hammershim procedure, the superior and inferior rectal muscle are isolated, and the shick ligament and intermuscular septum are separated from this muscle in the standard fashion. Each muscle is divided exactly in half. Here you can see they divide the muscle itself into a half, inferior half and superior half, then they transpose it. This is Hammershim. There is a splitting 14 millimeter from the center. Okay, then they transpose it. There they use a suture and they connect it to each other in Jensen procedure. I think it's more clear now. Here in figure 16.8, they make modification of transposition. They put more suture and they call it posterior fixation to make it more powerful, Hammershima procedure. I think I finish here and I will say thank you, but I want to hear if there is any question. Dr. Sarah, do you like to ask? Or Isra?
No, thank you.
Thank you so much. Dr. Muhammad, do you want to add anything else before we
No,
finish?
no.
Okay, thank you all. I hope we make something clear and something new for everyone. And I hope it's clear. Thank you so much. We will continue, inshallah, at Wednesday in this week for the next case. Assalamu alaikum fi amanillah.
Alaikum assalam.